Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs in the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
We have a handful of great questions today, and remember, you can always send us a question on LinkedIn or YouTube, or you can email it to us at hello@minglehealth.com. Okay, let's get started.
Thanks, Kyle. Roll them.
Our first question today is from Lisa, and Lisa asks, on promoting interoperability, will small practices automatically get a PI hardship for 2023?
Great question, Lisa. The answer is yes. Small practices no longer need to ask for a hardship exception for promoting interoperability. It's granted automatically, and it redistributes the points entirely to the quality category. So instead of 30% quality is worth 55%. If a small practice submits PI performance, it's scored. So no reason to let Medicare know what you're doing. They'll score it if they have it and forgive it if they don't.
Great. Our next question also comes from Lisa, and she's asking, on the adult immunization status measure, do you know if flu and pneumonia will have individual numbers, or will the score be a combination of both?
Oh, interesting question, Lisa. The answer is both. Adult immunization status measure now number 493 is new to MIPS measures for 2023. It's only available as a MIPS CQM. It's applicable to patients 19 and above. It's looking for patients who are up to date with influenza, tetanus, either as the DT or the Tdap, zoster, and pneumococcal vaccine. It's reported with a different numerator for each of those immunizations, and it's scored on a weighted average of all four. Thanks for the good question, Lisa.
Yeah, thank you, Lisa. Hope that helps. Our next question today comes from Lolita, and Lolita asks, was FHIR referenced in the 2023 final rule?
Interesting question, Lolita. FHIR was in fact mentioned in the rule as a request for information, both on Medicare's plan to advance digital quality measurement and on creating the Advanced Trusted Exchange Framework and Common Agreement, acronym TEFCA or TEFCA. There are no new standards, no new requirements for FHIR. It remains one of the methods of exchanging data. Anyone who's looking ahead to a single standard is looking to FHIR as most likely to be that standard. But I can't tell you from the rules when it's going to be a requirement. Data standard requirements are an interesting double-edged sword. Setting a requirement can dramatically accelerate adoption of that standard, but we don't really want to be grading organizations' ability to stick with the standards. We want to grade their quality reporting. And moving too quickly to the standard makes it more of a grading of your infrastructure, not of your care. So stay tuned. Someday we'll know more about FHIR and expect it to be a standard sometime in the next decade or two.
Our next question today comes from Lindsay, and Lindsay asks, are social drivers of health screenings only going to be required for the acute inpatient setting, or will ambulatory settings also be required to screen for SDOH?
Great question, Lindsay. Measure number 487, Screening for Social Drivers of Health, is a new measure available in the MIPS menu of measures in 2023. It's only available as a MIPS CQM option. It's not as an eCQM claims or web interface measure. It's included in most specialty measure sets, but not in anesthesiology, dentistry, electrophysiology, hospitalists, pathology, radiation oncology, speech and language pathology. And it's not really a requirement, it's just one of the options. I don't know if it will ever be a requirement. It certainly hasn't been the direction of most MIPS quality measures, although its presence in so many specialty measure sets now suggest that we may commonly see it as an option in the MVP measure sets. Thanks for the great question, Lindsay.
Our next question today comes from Mel. Mel wants to know, how do the yearly changes keep CMS value-based programs competitive with Medicare Advantage plans?
Fascinating question, Mel. I have trouble finding reliable data comparing traditional Medicare to Medicare Advantage. Established in 1997, enrollment in Medicare Advantage has been steadily increasing, hitting 48% in 2022. The Congressional Budget Office predicts that 61% of Medicare beneficiaries will be uh, in a Medicare Advantage plan by 2032. Now, according to the Kaiser Family Foundation, Medicare Advantage plans have never generated a savings relative to traditional Medicare. In fact, they tend to be more expensive. Typically, in 2019, Medicare Advantage cost Medicare $321 per beneficiary more per year than traditional Medicare, at $11,844 a year versus $11,513. It's really an apples to oranges comparison between Medicare Advantage and traditional Medicare. Medicare Advantage caps out-of-pocket expenses, so we may find that it actually improves expenses when you look at both what's output by Medicare and what's output by the beneficiaries. Medicare Advantage plans win bids to participate by bidding below the benchmarks of predicted Parts A and Part B service costs. But they can earn more from Medicare with rebates for extra benefits they provide. Medicare Advantage plans shape their enrollee profile through selective marketing, and they can shape their cost profiles through network selection. There are some studies showing that Medicare Advantage enrollees generally get their care from sources with lower quality ratings than traditional Medicare participants. And Medicare Advantage has been training longer on risk coding, so it's not necessarily reliable to look at HCC risk codes in each and expect them to really match each other. The traditional Medicare may be more complex at the same risk code level. So overall, relative to your question, Mel, I conclude that traditional Medicare is already competitive with Medicare Advantage, and the value-based care dynamics are likely to accentuate the dynamics that favor traditional Medicare by encouraging cost containment, attention to performance standards, attention to risk-relevant coding that makes the populations more comparable. Thanks, Mel. We'll keep an eye on this one.
Yeah, thank you, Mel. That was a great question. Our next question today comes from Trish. And Trish asks, can you comment on the role of historic MIPS scores when evaluating new practices for MSSP membership?
Trish, I like the way you think. It is absolutely something you should watch carefully as you build your ACO. Strategically, your path is clear. You want to be at or above the quality threshold to collect your full allotted share of savings. Tactically, what you do with any particular practice depends on the circumstances as you relate to both your ACO and the practice proposed for membership. Your ACO will be in one of two circumstances. You'll either be comfortably at or above the quality threshold, or you will be struggling to either get there or stay there. If you're struggling, it could be an expensive mistake to bring in a practice that will pull your scores down. It could be the deciding factor that means that you won't share in the savings you generated. If you're comfortably above the quality threshold, you may be able to count on the average score across your participants to keep you in the full sharing range. I'd suggest that you ask the proposed new practice to share their recent MIPS feedback reports to understand what they have been scoring historically. If they didn't submit any of the three measures of the APP, you could ask for credible data to establish historical expectations. There might be a canned report or a different quality program in which they participated, which could be predictive of where they will land. Also, I suspect that someone who's been able to bring other measures up to a higher performance level, if they've chosen 6 different measures than you're interested in, um, if they've been able to bring those measures up, it's predictive that they may be able to bring these 3 measures up reasonably well as well. You should understand how they were measured historically. Succeeding on a sampling of patients by manual chart audit is not at all the same as measuring at least 70% of all eligible patients of all insurers. Better yet, do a trial of their data with your reporting vendor to see where their scores land and will land you using the applicable specifications. There's an added advantage in this approach that you will also verify that their data is accessible and readable. Also, in your analysis will be your experience of how successful you are in providing support to practices to elevate your scores. If you find that they're responsive, you can get in and fairly quickly elevate their levels, you'll feel more comfortable about inviting new practices into the ACO who haven't had such good scores in the past. Thanks for the great question, Trish.
Great. Our next question today comes from Shafali. And Shafali asks, since the exceptional performance bonus has ended, what type of incentives are there for providers who score 95 or greater?
Great question, Shafali. Medicare is not yet in any year of MIPS truly graded on a statistical curve in which you'd expect 50% to suffer a negative adjustment and 50% to enjoy a positive adjustment. If it were truly balanced, you'd expect peak losses to be 9% and peak gains to be at least 9%. So few practices suffer negative adjustments. Positive adjustments have been driven mostly by the exceptional performance bonus. That exceptional performance bonus has driven peak positive adjustments to about 1.8%. Now, we've lost that foundational 1.8% with a lapse of the exceptional performance bonus. Offsetting that somewhat is a legislative requirement that the performance threshold be set at the average. Now, that average can be at the discretion of the Secretary of Health and Human Services, either the mean or the median, and it can be the mean or median of any prior year. So still not truly a statistical curve. With the phase-in dynamics since the beginning of MIPS and the COVID dynamics, we've not enjoyed a normal year of MIPS yet. Now, Medicare has floated their prediction for 2023 to be a 3% or better maximum positive adjustment. My guess it will all come in lower than that, and we will see something that's between 1% and 3%. But let's keep a watch on that one, Shafali. I'll let you know if there's any more information about that.
Our next question today comes from Sharon. Sharon asks, will our MSSP ACO with multiple TINs be eligible for the small practice exception based on the TINs participating in the MSSP? Meaning, multiple TINs are small practices that roll up into our basic track MSSP program. Will each designated small practice receive the automatic exception for PI?
Great question, Sharon. The answer is an equivocal yes and no. There are 2 applicable requirements for health IT in your basic track MSSP program that is not an advanced APM. One of those requirements is MIPS. All MIPS eligible providers in an MSSP ACO that is not an advanced APM has a MIPS requirement for promoting interoperability. That MIPS requirement is subject to all of the standard terms of any MIPS submission, including the automatic exception for small practices. So as far as MIPS is concerned, yes, all your small practices will receive the automatic exception for PI. But there's also an MSSP contracting requirement that 75% of participants be on certified EHR. Now, that contractual agreement is based on the attestation represented by the contract and subject to verification through audit. And it doesn't have the specific requirements of promoting interoperability that you have all of the functionality implemented, just that you're using CEHRT. Thanks for the great question, Sharon.
And our final question today comes from Liz. And Liz asks, what will the hospitalist measures look like going into 2023?
Great question, Liz. There's been one measure removed from the hospitalist's specialty measure set. Removed is measure 76, prevention of central venous catheter related infections. Continued are measure number 5, ACE/ARB use in left ventricular systolic dysfunction. Measure number 8, beta blocker use in left ventricular systolic dysfunction. Measure 47, advanced care plan, and measure 130, documentation of current medications. There are a few considerations as you decide what you will submit for 2023. First, consider facility-based submission. A hospitalist practice might qualify for facility-based participation. Remember that a provider is not an NPI, but a TIN NPI. In Medicare's eyes, a provider is a distinct entity in each of the TINs in which he or she bills. 75% of the billings, or when 75% of the billings come from a hospital location, the provider can claim that the facility quality score as his or her own, or the whole practice can claim the facility quality score if 75% of the providers are eligible for facility-based submission. Also, you can use any MIPS measure if you perform the quality action. You're not restricted to the hospitalist measures. If you're engaged with Mingle Health, our analysis of your claims can give you a complete list of the measures for which you have case minimums, and then you can decide which ones you participate in the care adequately to feel that you're controlling the measurement and you're eligible to submit that measure. Now, a big advantage of the specialty set is that the 4 measures in the set are considered a complete submission. You don't have to scramble to find 2 more measures that don't fit well. Those 4 measures count for the whole submission, then you don't need the 6 that most MIPS participants need. Thanks, Liz. Good question.
Yeah, thank you, Liz. And thank you to everyone else for the excellent questions today. Remember, you can always leave your questions for Dr. Mingle in a comment on LinkedIn or YouTube, or send us an email at hello@minglehealth.com. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle, and thanks to everyone for all the great questions. I want to be helpful, and I want this to be useful to you. Please correct or supplement my answers, share your experience, ask your questions. We can be smarter together.